Hello guys, I'm Deepak Shukla. Welcome to our channel Study Mania. Today let's learn about otosclerosis. Otosclerosis. Otosclerosis is excessive bony deposition in the middle ear, mainly in the foot plate of stapes. So it can be stapedial or it can be cochlear also. It is a disease of bony labyrinth usually. What happen here? Normal endochondral bone of otic capsule is replaced by irregularly placed spongy bones. Okay, so there was some normal endochondral bone that was replaced by spongy bone. Simple. Why it is happening? Due to excessive bony deposition in the foot plate of stapes, there will be problem in conduction for sure, and that will lead to hearing loss. That is conductive hearing loss in stapedial type. But in cochlear type, we have sensory neural hearing loss. Okay, so coming to the most common site of otosclerosis, we have fistula antifenestrum. Okay, anterior to the foot plate. Fistula antifenestrum is the most common site of otosclerosis. You have tried that. Okay, so how you'll find? Okay, in the posterior part we have pyramid. Okay, posterior wall of middle ear we have pyramid, and opposite to that is the anterior side. So this is pyramid. So this is the posterior part. Anterior to that we have, first thing is anterior focus, or the anterior crus of the foot plate is involved. Okay, if the posterior crus is involved, it is called posterior focus. If the whole circumference is involved, it is called circumferential. Okay, if only part of the plate is involved, it is called biscuit type, and if the crus and the plate everything is involved, it is called obliterative type. Okay, so the most common site of otosclerosis is fistula antifenestrum in stapedial type, that is anterior side, posterior focus, circumferential, you have to draw these diagrams, biscuit type and obliterative type. So these are the sites of otosclerosis. Okay, coming to types of otosclerosis, we have stapedial type, we have cochlear type, and then some histological type. In stapedial type, you will having the most common site as fistula antifenestrum. Please remember this fistula antifenestrum, that is anterior crus crura. Okay, here you will find conductive hearing loss. Whereas in cochlear type, round window is the most common site. You will find sensory neural hearing loss and tinnitus. Okay, so what is the etiology? Very important etiology, or you can call trigger factors. So these are, first one is hereditary. This is autosomal dominant with incomplete penetrance. Sex, female are more prone than males, but in India male is predominant. Age of onset is 20 to 40 years. There is some hormonal imbalance. Okay, so therefore it increases in pregnancy and during menopause. Okay, so there is increased progesterone that can result in otosclerosis. For example, oral contraceptive pills. Then measles can be a risk factor. Autoimmune disorders is also associated with risk factors. Along with those, we have some syndromes like Van der Hoof syndrome. This is also associated with otosclerosis. There is very nice photo where a blue sclera is seen, and along with that, osteogenesis imperfecta and otosclerosis is also there. Okay, so go see this image in the Google, Van der Hoof syndrome, osteogenesis imperfecta and otosclerosis. Blue sclera is typical feature of Van der Hoof syndrome. So what is the pathophysiology behind this? Okay, grossly what you can see is excessive bony deposition, and these are seen as whitish flakes. In cholesteatoma, what you were seeing was pearly white, and that was due to keratin. Okay, keratin deposition, but here you will see whitish flakes grossly. In microscopically, three layers are there: periosteal layer, endochondral layer, and then endoosteal layers. So let's see the pathophysiology of otosclerosis. Okay, so first thing is triggers. All those triggers that I have explained here, that is hereditary, sex, progesterone, OC pills, measles, autoimmune disorders, any syndromes, all these are the triggers. So these triggers will stimulate the endochondral cell rest, and when this endochondral cell rest is stimulated, that will stimulate osteoclast. When osteoclasts are stimulated, that will cause more of bone destruction and more of vascular activity. And this is a phase more of vascular activity, that is very important in a phase of diagnosis also. So here we'll say it as a blue mantle of Manasseh, that is bluish discoloration due to increased vascular activity, blue mantle of Manasseh. Okay, so this was a phase when osteoclast was activated or stimulated more, causing increased vascular activity and osteoclastic activity, leading to bone destruction. As soon as bone destruction starts, the bone starts remodeling by osteoblast. Okay, by osteoblast. So bone destruction causing bone, thereby causing bone remodeling, and after some time it will cause spongy bone formation, and after some period of time, that will replace the spongy bone, will replace this normal endochondral bone, and with a period of time it will become sclerotic bone. Okay, so this was the pathophysiology, like normally from the triggers, then to the endochondral cell rest, then to the how to stimulate the osteoclast, and then increase vascular activity, then remodeling by the osteoblast, spongy bone formation replacing the endochondral bones, and then at the last sclerotic bone formation. This was the pathophysiology. In active lesions, what you'll see is there is numerous spongy irregular bone. Okay, numerous spongy, like till here it is active lesions. Numerous spongy or irregular bone is there. There is increased vascularity, there is increased osteoblastic in numbers. Okay, this is the initial part of the disease, that is called proliferating part, and therefore it is called the active lesion. But in inactive phase or inactive lesions, this is the end stage. Therefore you'll have solid or sclerotic bone. Okay, so this is the end stage or inactive phase, but till here it was the active phase. Coming to the symptoms of stapedial autosclerosis. The symptoms of stapedial autosclerosis. Okay, stapedial means we have conductive hearing loss. Important to remember. The most common feature is conductive hearing loss, that is bilateral conductive hearing loss. Sometimes mixed hearing loss also, that is rare. Then tinnitus may also occur. The most important after conductive hearing loss feature is paracusis willisii. So if someone asks where will see paracusis willisii, it is in otosclerosis. What is that? Patient hears better in the noisy environment as compared to silent environment. So this is paracusis willisii, that is seen in the stapedial type of otosclerosis. Coming to symptoms of cochlear otosclerosis. Cochlea. So cochlea is involved means inner ear is involved, means some kind of sensory neural hearing loss. Okay, so here we will see sensory neural hearing loss, tinnitus, vertigo, and there is no paracusis willisii. Paracusis willisii is seen in the stapedial type of otosclerosis. So what are the signs that we can elicit? Here most of the time tympanic membrane is normal and tympanic membrane is mobile, means the stapes is not fixed to the tympanic membrane. Third is sword sign. Okay, so while explaining the pathophysiology, I told you about a phase, that is increased vascular activity and increased osteoclastic activity, that is blue mantle of Manasseh. Due to that active lesion, they have flamingo pink hue on the promontory. Flamingo pink hue on the promontory, and that can be seen through intact tympanic membrane. This is called sword sign, seen in 10% cases only. Okay. Now coming to the tests for stapedial otosclerosis. So as you know, in stapedial otosclerosis, we will have conductive hearing loss. In conductive hearing loss, word lineage will be negative. Okay, why negative? Because bone conduction is more than ear conduction. Okay, Weber's will lateralize to the abnormal ear because of conductive hearing loss. Weber lateralized to the abnormal ear. Absolute bone conduction is normal, Gillies test is negative. Tympanometry, like it shows AS type of graph, it is very specific to this. Stapedial reflex is absent. Okay, because stapes is being, like bones are there, spongy bone, so reflex is absent. And in pure tone audiometry, it is very important, you will have Carhart's notch. Okay, so how to remember in Otto, suppose this 2 as otosclerosis, Otto has 2, so you can remember at 2000 hertz there is sudden dip in bone conduction. Simple. Okay, so in pure tone audiometry you will have Carhart's notch, that is at 2000 hertz maximum dip in bone conduction. See, bone conduction was here, at 2000 suddenly dip is there. Okay, so this is Carhart's notch, it is seen in otosclerosis. Okay, so in air conduction, abnormal range, lower frequencies are affected first. Okay, bone conduction maximum dip at 2000 hertz, that is known as Carhart's notch. Okay, so Carhart's notch is seen in otosclerosis, and by OTO2 you can remember 2000 hertz. And this stapedal reflex, it can be reversed back after stapedectomy, and this Carhart's notch also it can be reversed. Coming to the cochlear otosclerosis, the most specific is AS type or tympanogram. Okay, since cochlear is SNHL, so here we have SNHL, readiness positive. Okay, air conduction, bone conduction denotes SNHL. Weber lateralizes to the normal ear. Absolute bone conduction is shortened. Okay, so in pure tone audiometry you will have cookie bite curve. Okay, cookie bite curve. Cookie bite curve means the dip in the mid frequency. Dip in the mid frequency of both air conduction and bone conduction. So this is the cookie bite curve. Like, okay. Coming to the treatment, medical treatment, we have hearing aids. Then we have sodium fluoride. What is the work of sodium fluoride? It has to be given in the active phase only. Sodium fluoride, it is given to arrest the active focus only and to prevent the further sensory neural hearing loss to cochlear otosclerosis. So what is the mechanism? It inhibits the osteoclast and thereby inhibit the proteolytic enzyme release. Okay, so it inhibits the osteoclast. When osteoclast is inhibited, the enzymes that were about to release are also inhibited, so thereby inhibiting the bone destruction. So when sodium fluoride is given, there is no further bone remodeling and there is no new bone deposition. Okay, so it is given only in the active focus when there was osteoclastic activity. So you have to inhibit those osteoclastic activity so that there is no enzyme release, no further destruction. Okay, so sodium fluoride is given. What are the contraindications of sodium fluoride? That is very important. If pregnant lady is there or lactating lady is there, in renal disease and rheumatoid arthritis and skeletal fluorosis, sodium fluoride is contraindicated. Coming to the surgical management, what are the surgery options that we have in otosclerosis? The first one we have is stapedectomy. Stapedectomy with placement of prosthesis is treatment of choice. Then we have stepedotomy and placement of prosthesis, but here there is more chances of recurrence. Stapes mobilization, and the fourth one is Lampert's fenestration operation, reserved only for cases where foot plate cannot be mobilized during stapedectomy. Okay, so that foot plate, it is being fenestrated in case when it is not mobilized during stapedectomy. So we have four options: stapedectomy with placement of prosthesis, stepedotomy and placement of prosthesis, Stapes mobilization, Lampert's fenestration operation. Okay, so let's see what are the indications for the surgery. If hearing threshold is 30 decibel or AB gap is 25 decibel or more, and there is AS type of tympanogram, we can go for the surgery. If there is bilateral otosclerosis also, then worst ear is operated first. And if there is speech discrimination above 60%, then we have to go for the surgery. Okay, hearing threshold 30 decibel हो गया है, bilateral otosclerosis is there, and speech discrimination more than 60%, then we have to go for surgery. Contraindications for surgery is if it is the only hearing ear. Okay, like left ear is already gone and only right ear there is otosclerosis, it is already gone, here there is also chances, so surgery is usually not preferred. Pregnancy or children less than pre-adolescent or above 70 years, and if occupational, like a person who has to like pilots or drivers or divers, in those cases it is contraindicated, or they are suggested to change their profession if possible. So we have to do it under the local anesthesia. Why? Because to assess the improvement in hearing during the surgery only. Okay, so local anesthesia is more preferred to assess the improvement in hearing only. Okay, while on the table patient is there and we have to assess his hearing, so local anesthesia is preferred to assess the size of piston use and to assess for any complication, that is intraoperative complication like perilymph leakage or facial nerve damage. So assess the complication on the table only, we have to go for local anesthesia preferably. Coming to surgeries, We have stepedotomy. Okay, stepedotomy. So here just a hole is made and the prosthesis or piston is inserted, okay, through the hole in the foot plate, and wire fat prosthesis is placed. So the foot plate is intact. Okay, the foot plate is intact, only a hole is made and a prosthesis is put, but there is more chances of recurrence. In stepedectomy, foot plate is removed. Okay, means here whole thing is removed. Now while removing the foot plate, suppose this foot plate is attached to this, while removing this foot plate, there is some micro tears will be there, high chances of perilymph leakage will be there. Okay, so this was attached to this, while removing there is some dot like some micro tears will be there, so there is chances of more perilymph leakage due to the peeling foot plate from oval window has higher risk of tears and leakage, but there is less chance of recurrence, so stepedectomy is more preferred than stepedotomy. What are the complications of surgery? That is very important also. So perilymph fistula, they have told, recurrence due to displacement of prosthesis or new bone deposition, necrosis of the incus, okay, when there is tightly placed piston, and facial palsy, okay, because facial nerve lies close to the foot plate. When do you abandon the surgery? It is very important to say no to something, say no to the surgery when there is low lying facial nerve or facial nerve is lying over the foot plate. So if you disturb the foot plate, facial nerve is disturbed. If there is persistent stapedial artery and floating foot plate, there is higher chance of perilymph leakage. So in these three cases, that is low lying facial nerve and persistent stapedial artery and floating foot plate, we should try to abandon the surgery. So this was about the otosclerosis.